Ruptured ectopic pregnancy within the emergency department. According to the American Pregnancy Association, an ectopic pregnancy occurs when the fertilized egg attaches itself to a place other than inside the uterus. Almost all ectopic pregnancies occur in the fallopian tube and are often called tubal pregnancies. The fallopian tubes are not designed to hold a growing embryo. Therefore, the fertilized egg in a tubal pregnancy cannot develop properly and must be treated. Ectopic pregnancy happens in 1 out of 50 pregnancies. Signs and symptoms of an ectopic pregnancy are often similar to those in a normal pregnancy, such as nausea, vomiting, breast tenderness, constipation, frequent urination, fatigue, mood changes, and weight gain, and sometimes dizziness. Signs and symptoms more directly related to a tubal pregnancy are sharp stabbing pain that may come and go in the pelvis or abdomen, vaginal bleeding, light or heavy, GI upset, weakness, dizziness, and/or fainting. A ruptured ectopic pregnancy is a medical emergency. As the embryo grows, it can cause the tube to tear or burst. This results in dangerous internal bleeding and requires emergent surgery. Signs and symptoms of impending or active rupture include sudden severe abdominal pain or pelvic pain that may radiate to the back, dizziness and/or fainting and/or orthostatic hypotension, pain in the shoulders due to leakage of blood in the abdomen affecting the diaphragm, and other signs and symptoms of hypovolemic shock. Complications of tubal pregnancy and/or rupture are internal bleeding, which can lead to hypovolemic shock, salpingectomy, which is when only one of the fallopian tubes or both are removed, leading to hormonal imbalances, infertility, and sometimes maternal death. My patient presented to the emergency department by squad after having moderate abdominal pain in the right lower side and that radiated down to her groin. The patient reported feeling dizzy, diaphoretic, and fatigued while at work that required her to sit down. The patient reported that she had been seeing a fertility specialist and had been trying to get pregnant for several months, but was told it would be almost impossible for her to get pregnant due to her having a history of uterine polyps and fibroids. Risk factors for ectopic pregnancy include abnormalities to the fallopian tubes, pelvic inflammatory disease, history of ectopic pregnancies, pelvic and/or abdominal surgeries, previous tubal surgery, endometriosis, infertility or infertility treatment, intrauterine devices such as an IUD, increased age, and drug use or tobacco use. In order to confirm an ectopic pregnancy, a pregnancy test must be obtained by way of either urine or blood. In the instances of this patient, her urine test came back positive, therefore we proceeded by getting a transvaginal ultrasound at bedside. Early detection of an ectopic pregnancy is important because oftentimes patients remain asymptomatic until impending signs and symptoms of rupture occur. Early detection can lead to prompt initiation of treatment, resulting in improved clinical outcomes. Ectopic pregnancies can be detected through obtaining a pregnancy test, getting an ultrasound, as well as looking at the patient's blood chemistry and oftentimes a speculum and bimanual pelvic exam. Management of an ectopic pregnancy varies depending on the extent of fetal development. Expectant management is when the patient is watched closely by a physician instead of immediate treatment. In expectant management, no treatment is given and the patient is followed closely with weekly transvaginal ultrasounds and weekly blood measurements of HCG levels until the level is less than 10. Expectant management may be advised when an ultrasound scan shows a small ectopic pregnancy with no bleeding into the abdomen, low or declining HCG levels, and a patient is willing to come in for close follow-up, as well as when an ectopic pregnancy is suspected but clinically fails to show an ectopic pregnancy. Medications can also be used for an ectopic pregnancy. Some medications are methotrexate or mifepristone. They are used for the treatment in very early stages of the ectopic pregnancy when the tube has not ruptured. These drugs stop the further development of pregnancy and it is gradually reabsorbed into the body, leaving the fallopian tube intact. The success rates of medical treatment vary 65 to 95% depending on the circumstances in which the methotrexate or other medications are given. Follow-up visits are required for a few weeks to ensure pregnancy has completely ended, and a reliable contraception method should be used for at least 3 months, or sexual intercourse should be avoided. Surgery is also an option for people who have an ectopic pregnancy. Surgical management is performed to remove the ectopic pregnancy and is the most established form of treatment. Surgery may also be performed if the expectant management and medical management has failed. And an ectopic pregnancy can be removed from the fallopian tube by using two types of surgical procedures called a salpingostomy and a salpingectomy. These procedures can be performed either laparoscopically or laparotomy. After the procedures have been performed, the tissue is removed and can be sent off to lab for testing. After having an ectopic pregnancy, the chances of having a successful pregnancy in the future are good. If only one fallopian tube is present, chances of conceiving are only slightly reduced. And get an initial set of vitals. The next step would be to establish access and obtain blood samples. If an ectopic pregnancy is confirmed, the patient is at risk for rupture, and a large amount of blood would be lost, so the blood typing and cross-matching would be done in anticipation of a blood transfusion and/or surgery. The blood sample would also be used to determine the hemoglobin levels in the pregnant woman. Next, the nurse is also responsible for administering medications such as the methotrexate or mifepristone, as well as other medications to control the patient's symptoms. IV therapy is also very important. This would be performed when the ectopic pregnancy has ruptured and/or has already ruptured to restore intravascular volume due to bleeding. Overall frequent monitoring for any changes in vitals and/or presentation that may indicate the patient's condition may be worsening is needed. My patient was a 30 to 35-year-old female with a history of uterine polyps and fibroids who had been receiving fertility counseling in order to get pregnant. She had no previous pregnancies and was actively trying to get pregnant after being told she had little to no chance of being able to. The patient presented to the emergency department with increasing right-sided abdominal pain, orthostatic hypotension, nausea, vomiting, dizziness, and tachycardia. After an hour in the ED, the patient's pain became severe and her vitals began to drop. Her blood pressure dropped to 70s over 50s and her pain was unbearable. At this point, a ruptured ectopic pregnancy was confirmed and we needed to act quickly in order to keep her stable and prepare for surgery. During her time in the ED, I collected assessment data that indicated the patient had in fact ruptured and was going into hypovolemic shock. Hypovolemic shock refers to blood loss that makes the heart work harder in order to pump enough blood to the body. This type of shock can cause many organs to fail. The assessment data I collected was that the patient was hypotensive with pressures in the 70s, tachycardic with heart rates in the 1-teens, tachypnea with stable SpO2 levels, and the patient was also experiencing dizziness, especially with position changes due to the hypotension, diaphoresis, and nausea and vomiting. The diagnostics confirmed a positive HCG in her urine and a positive ectopic upon transvaginal ultrasound. Her blood work indicated an elevated lactic acid level as well as elevated white blood cell count indicating shock. The goal for this patient was to maintain hemodynamic stability. In order to do so, continuous monitoring and fluid replacement was needed. In order for this to be successful, it was important to keep the patient calm and inform her of what the plan was. It was also important to work closely with the other members of the interdisciplinary team, such as the ultrasound technician, the OB resident, as well as the OR staff to prepare for emergent surgery. The nursing interventions related to my specific patient consisted of obtaining 2 access points for which I placed an 18-gauge IV in both arms. She was then given a total of 4 bags of normal saline hung to gravity to maintain blood pressure and replace blood loss. A bedside transvaginal ultrasound was ordered due to the fact that the patient was unstable to be transported. She was given Zofran IV for nausea and vomiting to prevent further fluid and electrolyte loss. Blood samples were obtained for a type and screen as well as an Rh compatibility test. Vitals were obtained every 5 minutes and the patient had continuous telemetry monitoring on, as well as visual eyes on the patient frequently. An OB resident was paged to come down to bedside to proceed with further planning. Communication between the OR staff and OBGYN was vital to prepare for emergent surgery. Consent was reviewed with the patient to discuss the plan to undergo surgery, and the risks were discussed. A WINGS packet was also provided to the patient with education about how to proceed with fetal demise and grieving resources and options. Within an hour and 30 minutes, the patient was prepped and transported to surgery with an RN at bedside throughout the entire transport. An algorithm for an ectopic pregnancy could go as this. First, a woman comes in with complaints of abdominal pain, amenorrhea, and or vaginal bleeding and is in fertility age. A urine test is performed. If the test is negative, then ectopic is ruled out. If it is positive, then an ultrasound and a blood HCG level is required. If the patient is positive on there and the patient is non-symptomatic, then expectant management. If the patient is symptomatic, then you must prepare for surgery and possible rupture. Therefore, you should get a cross and screen, get medications for the symptoms for pain, nausea, vomiting, and place 2 peripheral IVs. From there, you should go ahead and proceed with fluid replacement as needed and prepare for surgery by getting consent, giving the WINGS packet, discussing potential complications, collecting patient belongings, and calling the needed team. It is also important to go ahead and tell the patient what is expected and what to do after the surgery. From there, they will prepare to get some kind of surgery to either remove the ectopic pregnancy and or completely remove the fallopian tube, which is up to the MD's discretion.